This is Orsi, the Old Guy at oldguytalkstome.com, a podcast dedicated to helping older guys create kick-ass lives for themselves and those that they love. Join me regularly as I share my interviews with experts on various topics that include anti-aging, sex, relationships, and other things that will help you create that life that you want. Now, I want you to do three things. First of all, I want you to subscribe so you don't miss any of this life-changing information. 2, share it with others. And 3, review. Be sure to do all 3. And now for our podcast. This is Orsi, the official old guy at oldguytalkstome.com, a podcast dedicated to helping older guys create kick-ass lives for themselves and those that they love. And, there's lots of cool shit that we talk about. Some of it's important, some of it is trivial, but all of it will help you create that kick-ass life that you want. And today in the house, I got Scott Howell, PhD. He's also an MD, but he's not licensed to practice. And we're going to be talking about some stuff. Now, if you are interested in the other stuff that Scott has and I've talked about, we've talked about how those numbers that the doctor tells you that you're fine, but you feel like shit. Well, we go into great detail about that. But Scott is a smart dude. You do not want to argue with this man. If you want to argue with this man, you better bring like a shitload of facts, because he reads, Scott, I think you told me you read like 10 or 12 studies a day. That's pretty amazing. He's an author with expertise spanning many fields, including sports science, integrated periodization, and sports training. I can't even say it. Sports training and athletic development. And he's also writes for the Journal of he writes for the Journal of Physiology and Endocrinology and Metabolism, and the Journal of Encyclopedia Ethnopharmacology, Pharmacological Research, and the Yale Journal of Biology and Medicine. And just saying that is really, really hard. Just reading it out loud. These are big ass fucking words. But we're gonna bring it down so you don't have to be Googling these words while we're talking. And we're gonna talk about something. If you are taking testosterone, and you go in a lot of these T-box clinics out there that they kind of got a formula, and I think most of the time it includes, and I'm sure Scott will correct me if I'm wrong, they'll include testosterone and aromatase inhibitor and maybe some HCG, depending on the particular belief system those clinicians have. And there's a lot of shit about aromatase inhibitors that, well, you need to know. And then we're also going to talk a little bit about Hematocrit and RBCs, a situation that the old guy just ran into a while back. Unfortunately, we got resolved. So, Scott, thank you.
Thanks for having me on, Horace. It's always a pleasure. I have to correct you on that one point. I pull about 20 studies per day.
Oh, you pull? Okay.
I read 1 or 2 per day, but I do pull sometimes 20 or 30 per day. But as far as what you're talking about with aromatase inhibitors and T-mills, it's something that both myself and Dr. Nichols has been very passionate about, because we met on other sides of the literature. And I actually met Dr. Nichols by sending emails to prominent TRT physicians over the course of about 2 or 3 years. And I was asking them, we're telling them that I had a belief based on the evidence that blocking estrogen was causing harm. And I wanted to reconcile the differences in our beliefs by working on a literature review together and then publishing it. And I sent it to at least 20, 30 clinicians. One physician responded to me, and it was Dr. Nichols, and he told me he didn't use aromatase inhibitors. And so that one email is how I met Dr. Nichols. So I had to trace the origin of where this crossover from bodybuilding actually occurred into testosterone replacement therapy. Because if you look at the evidence early on, there was no aromatase inhibitor use. These drugs were developed to treat breast cancer. So they were given to females. And so there was other things like tamoxifen, which is an estrogen receptor modulator to a certain extent. It blocks estradiol from binding. But what I had to do is try to figure out how this crossover actually happened. And so when I triangulated a bunch of different studies, and they kept on going to these certain citations, ended up having to pull them. And so this study that I have here by Pavlovich in 2001, this is used by T-mills as evidence that they should control the androgen to estradiol ratio by blocking aromatase. So this study by Pavlovich was a study of 63 patients with male in-factor infertility that was severe. Over half of these patients had Klinefelter syndrome and other genetic disorders related to the androgen receptor.
So what's Klinefelter syndrome?
Klinefelter syndrome, it's a disease that is related to the androgen receptor, that these individuals do not have sensitivity to androgens.
Okay.
So they have to almost always go on testosterone treatment, and sometimes their dose has to be titrated several times. But the issue here is that they have pathology of the androgen receptor. And these other individuals that are in here, I'm going to, I have a chart here that I would like to actually talk about. So there was a portion of patients in this study that had chromosomal anomalies, cryptocordism, they had chemotherapy, they had varicella. There was one section for idiopathic that just had a few, but most of these individuals were highly comorbid with genetic disorders. And so the baseline levels that they found here in established androgen to estradiol ratio are not for otherwise healthy men on TRT.
Yeah. So what you're saying is that would not be the group of people that you would be picking to participate in a study if you were screening people for that study.
Well, definitely. I mean, the average, well, the FSH levels of these guys range from like 12 to almost 40 on average. Mm-hmm. So, I mean, if you look at this,
and I'm going to back you up because a lot of people aren't familiar with FSH. What does that mean, and what kind of things did you would expect in terms of numbers there?
Well, with follicle stimulating hormone, it's one of the things that with luteinizing hormone, that if we see higher levels of it, but then there's not a production of testosterone, the Leydig cells do not respond, then we can sort of determine that there's a cellular failure of the testes to produce.
Okay, sure.
Now, so with these type of pathologies, these levels can go either way. They can go off the charts sometimes. So for me, an FSH of 40 is pretty darn high. But to actually take this data and use the cutoff that they established to have an androgen to estradiol ratio of 10, and then apply it to men on testosterone therapy, it violates fundamental research theory and practice that you can't extrapolate outside of the population you studied. So they took highly comorbid individuals, and it only applies to these individuals that you would want to do that, even if you would want to. But my point is that you can't use an androgen to estradiol ratio established with highly comorbid genetic disease and say it applies to someone that's otherwise healthy, except for testosterone deficiency.
Sure. Now, just a kind of a brief rundown. What supposed issues, and when you talk about bodybuilding, I assume that's the same thing as bro science. When you talk about what supposed issues is aromatase inhibitors supposedly helping with?
Okay, well, most bodybuilders are into symptomology, and it's they want to drop water weight. Is what they want to do.
And you, just for everyone's sake, you yourself used to be a bodybuilder.
Yes, I did. I used anabolic steroids for about 10 years of my life. So I understand this population of people, and it's one of the reasons I actually started a lifelong study of illicit androgen abuse to gain a better understanding of the effects of these drugs, because there was so much nonsense and misinformation that was being peddled on these forums that no one could really make an accurate assessment of whether of the safety of using these compounds. And so that was a struggle for me. But one of the things that I did see early on was supposed estrogen symptoms. Now, if we look at water retention, for example, and so water retention is one of the most often mentioned symptoms that is attributed to aromatase estradiol.
Mm-hmm.
So people get it in their mind that it is the estradiol that's causing this effect. Well, if you look at what cocaine, he's the godfather of anabolic steroids. He started developing these drugs in he actually dubbed the term in the literature in 1946. And what he found was that all androgens, synthetic androgens that were from parental forms, meaning derived from testosterone, 19-nortestosterone, or DHT, that each of these had several key effects. And number one, the ability to retain nitrogen, but also other minerals like calcium, phosphorus, potassium, etc. So all androgens have that ability if they are derived from parental forms, but it varies from compound to compound and also into species of animal that the drug is used on. So my point here is that if we look at what has been shown in the literature, testosterone will increase antidiuretic hormone, okay? But estradiol, when it's aromatized, counters that effect. So when guys go on testosterone therapy, for example, some guys will get extra water weight, but they won't let the period go long enough for the treatment for the aromatase estradiol to level out to the dose that they're on. Mm-hmm. And so usually across the board in 3 months, that water retention it's not there anymore because aromatase is not blocked. So there's a counter effect. Testosterone and some androgens will increase antidiuretic hormone, and estradiol will lower it. It attenuates the effect. So when we block it, we're actually shooting ourselves in the foot on water retention. It's not what's the estradiol is not causing the water retention. It's the testosterone.
Sure. So, so let's get into the things that first of all, I think we talked about this in a previous time we were together, that there is there's a genetically predetermined balance for each individual between testosterone and estrogen in your body and conversion and all that. Is that correct?
Yes. Well, actually, the aromatase gene in mammalian vertebrates is a fail-safe mechanism. And it actually is thought to co-evolve with the androgen receptor gene. And why it's a fail-safe mechanism is because it regulates by your own internally produced androgens the amount that gets aromatized by the aromatase enzyme into estradiol. So if you think about it, it's a fail-safe even with exogenous therapy, because if you input a certain amount of testosterone, you will get the correct amount of estradiol for cardiovascular protection, for binding, and all the tissues that contain the aromatase enzyme. And see, a lot of people, they talk about having higher body fat and then having higher levels of aromatase because of body fat. Well, if you look at all the trials that's been done, long-term prospective studies, they never put obese men on aromatase inhibitors, because when they put them on testosterone therapy, that aromatase gene autoregulates, just like the androgen receptor gene autoregulates. And so they even out and they lose weight. They're not obese after 5 years. I mean, it's pretty profound changes that occur, but anytime, and if you look at this, it's ubiquitous. It's across the literature. Anytime you block aromatase or you interfere with the aromatase enzyme, there's similar pathology at both ends of the spectrum.
Okay, all right. So basically, when you take aromatase inhibitors and under testosterone therapy, you're basically screwing with your body's mechanism to deal with the increased amounts of testosterone, because it's just literally, as you mentioned, it's fail-safe and it's built in, and it's predetermined genetically in terms of what that ratio and balance should be.
Yes, and the aromatase gene also, but for example, with the androgen receptor gene, in conditions of high androgens, meaning if you take a certain dose and then you increase the dose, well, androgen receptors will upregulate in the dose response based on physiologic levels. The aromatase gene has some capacity there to auto-regulate the amount of the enzyme that's in aromatase tissues. So any tissues that have aromatase, that gene can auto-regulate to some extent.
Yeah. Okay. So, Scott, let's get into this stuff here now about what the damage, because it goes over several organ systems. What's the damage that's caused by basically prescribing aromatase inhibitors in these men?
Well, there's a lot of damage, and so if we have to look at it. I'm going to try to break this down in a way that it's not so complicated. So if we consider cardiomyocytes or myocardium, binding of estradiol to estrogen receptor beta and alpha are both essential to maintain proper cardiac health in men and women as well, but it's different for men. In the absence of this binding, there's an adaptive hypertrophy of the heart from androgens that is magnified, and it begins this progressive pathological remodeling. And it's one of the phenotypes of injury that I found early on when I was looking, and how I came across this, I was looking at androgen receptor knockout studies, estrogen receptor knockout studies, and aromatase gene knockout studies. And I was also looking at case reports of athletes and bodybuilders where they had died and they sectioned their heart. And what I found was almost identical pathology, diffuse collagen infiltration that ultimately leads to a loss of conduction velocity from the apex of the heart up through the Purkinje fibers upwards. So over time, this pathological remodeling, it's due to angiotensin II. And so angiotensin II is the main culprit behind it, but estradiol binding to these receptors prevents it. And it prevents it through several pathways. If you look at membrane-bound signaling, this prevents cardiac hypertrophy. If you look at just regular ER bonding to cardiomyocytes, this works in kinase signaling pathways that attenuate pathologic cardiac hypertrophy. So if you have people that train and they're not taking testosterone, non-testosterone therapy, most of these individuals, if they train consistently for long enough, they'll have some degree of left ventricular hypertrophy, which is athlete's heart. Well, when someone is on testosterone and then they use an aromatase inhibitor and prevent this bonding, the normal modeling of the heart, the structure of the heart, the size of the heart that's maintained by androgens is magnified, and it goes in the opposite direction. So on one end of the spectrum, if you go in the other direction, you knock out androgens, the heart becomes small, but it still has that collagen remodeling in it. Now, if you knock out estradiol, but you still have the androgens high, then the heart becomes even larger. And that's what you see across the board in case reports of bodybuilders. If you look at Dallas McCarver, he was a professional that just died 4 or 5 years ago. I measured all his organs against a normative standards. His heart was 933 grams. It was 3 times the size of normal. His liver was almost 3 times the size of normal.
Wow.
But what really got me was his lungs were twice the size of normal. And I was thinking in my mind, well, how does that happen? How does the lungs grow? They're postmitotic. They don't really repair themselves well.
Correct.
But it was angiotensin II. That's a lot of what he experienced was angiotensin II remodeling.
So basically, when you are on the aromatase inhibitors, the cardiovascular protective effects are basically negated.
They're completely shot out the window. And if you think about it even further, you have to have estradiol in bone to maintain bone mineral density and health. It's not just androgens. There's a whole plethora of effects. Now, I have some there was this one review that really influenced me to keep digging in deeper into aromatase about 5 years ago. And so this review basically said that if we really wanted to know the harm of using aromatase inhibitors, that the best that we have now is to look at conditions of true aromatase excess or deficiency. And so if you look at the brain, if there's aromatase deficiency in the brain, knockout studies show that estradiol is neuroprotective and essential to the integrity and survival of dopaminergic neurons, mood stabilization, and normal sexual behavior in males. So that's just the brain. If you look at immune and cardiovascular, estradiol is essential and bodily protective on the immune and cardiovascular systems, both. It's across all the literature. Now, if you look at liver and adiposity, if you have an aromatase deficiency, this correlates with negative lipid profiles, increased adiposity, and an increase in visceral body fat. Now, that visceral body fat is one of the highest risk factors for cardiovascular disease. It's a major source of inflammation. Mm-hmm. So in the absence of estradiol and insufficient levels of estradiol, visceral adipocyte number and volume increase across the board. Now, the quickest way to develop a fatty liver would be to take an aromatase inhibitor while you're on testosterone therapy. Mm-hmm. And if you look at if you look at deficiency, almost all across the board in animal models, these animals develop hepatic steatosis. They develop fatty livers. But when they're treated with estradiol, it resolves that fatty liver.
Oh, really? Okay.
Yes. So it's eliminated across the board in experimental models. So if you look at men with true aromatase deficiency, all these guys have extreme insulin resistance, and they have impaired carbohydrate metabolism. And these findings of looking at men with true aromatase deficiency, these have been replicated in aromatase knockout models and shown to result, when they knock out the aromatase gene, to result in metabolic syndrome in those animals. Mm-hmm. If you look at lipids, the typical lipid profile of someone that has aromatase deficiency is elevated triglycerides, a low circulating HDL cholesterol, and both of these fully resolve after treatment with oral estradiol. So when we look at the bone, men with aromatase deficiency, they have an increased bone activity. And it's remodeling, but it's not favorable. And it results in unfused epiphyses and reduced bone mineral density.
So basically, to put that kind of in layman, basically what they're remodeling is brittle bone.
Men avoid treating their erectile dysfunctions for two major reasons. One, they're too embarrassed to go to the doctor or even talk to their significant other about it. Two, the cost. You hear about all these ads on television or radio and the internet, and then you find out, well, those treatments are $3,000 and up. Well, I want to share with you a new device that allows you to get medical grade erectile dysfunction therapy in the comfort and privacy of your own home at a fraction. And I'm talking about a fraction of the cost of what it costs to get it in a doctor's office. And they even have payment plans. Check out the link below. You're going to be glad you did. Don't suffer. Don't be embarrassed. You'll be glad you did.
Definitely. It's almost like rubber. And so the long bones, they never close off at the epiphyses. So they don't have full plate closure. And so in the case studies that you see in the literature, what do they treat them with? Oral estradiol. And as soon as they do that, they can have plate closure in 6 to 9 months. So it's really profound that you see, I can see these things, but people still want to prescribe aromatase inhibitors to men.
Yeah, I'm shocked. I'm surprised because this is the first time that I've heard of estradiol being used therapeutically to treat a number of diseases in men, and that's certainly not. What kind of a doctor? I've never. I mean, I'm an old guy. I got Medicare card and everything. So official, government certified. And so what kind of doctors actually would this be an endocrinologist that'd be using estradiol, things like that? Or
it's really disappointing as you would think endos across the board would. And in two of the case studies that I've looked at, they were endocrinologists that administered. They gave testosterone first, it didn't work. And so they gave the man estradiol to get full plate closure. But most times across the board, you'll only see oral estradiol used in men in preventative medicine.
Mm-hmm.
That's it.
Okay. So that's a very select group of doctors that would be doing that.
Well, if you think about prostate cancer, I just sat through one of Dr. Neil Rousier's lectures maybe 2 months ago, and he talked about individuals that he's treated effectively for prostate cancer with oral estradiol. And so if you look at the lipid levels, and he puts the lipid levels up, he looks at the blood, shows everyone the blood levels, shows the course of treatment. And if you look at the lipid panels, these men that have prostate cancer that are being effectively treated, their lipid panels are perfect. I mean, you couldn't get better lipid panels.
Mm-hmm. That's really interesting. So the heart and the bone and what other organ systems are the brain you mentioned also is affected by that?
Sure. The brain is, if you think about any type of tissue, really, it's a target tissue for androgens. It's also a target tissue for estrogens as well. And there's one thing that I had to note here. Back up to what I was looking at was when I looked at these knockout studies that reintroduced estradiol to androgen deficient animals, what they concluded was that the estradiol was neuroprotective, and it was essential to the integrity of the dopamine neurons. So the neurons in those animals that produce dopamine, it was protective for that, and also mood stabilization, but also sexual behavior in the male animals. So if you look at the easiest way to tank someone's libido is to titrate up 0.5 milligram of anastrozole a day until they have a limp dick. That's how you can get ED as quick as you can. And it's a running joke. And I didn't even come up with that. That was something that was told to me at a conference one time. And it really does make sense because a lot of guys just think that they can fully tank estradiol and it's not going to have an effect on anything else, but it is essential for erectile function. It produces nitric oxide just like testosterone does. There's a lot of effects, but so there's some main points that I found going through the literature that what the body of research suggests. So the first is that there's an optimal cellular physiology of sex steroid target tissues that vitally depends on an androgen to estradiol ratio rather than either of those single hormones in isolation. Now, I'm not saying that it's the androgen to estradiol ratio of Pavlovich. What I'm saying is it is unique to you. If you're otherwise healthy, you don't change it.
Right.
And so this ratio is controlled in vertebrates by the aromatase enzyme. And these levels are set by the aromatase gene. And if you alter the ratio in any direction, you're going to have pathologies on both ends of the spectrum. And the fourth point was that aromatase, it truly is a fail-safe mechanism, and it's to protect organ systems, and it doesn't result in excessive levels of estradiol unless the individual needs it physiologically. So we're looking at organ protection. And even in athletes and bodybuilders that take really high doses of testosterone, they should not be on an aromatase inhibitor because that ratio is what's important, not the actual dose.
Not the actual numbers that you get. That's the ratio between the testosterone and the estradiol is really key, and that's determined by your body, preset genetically.
Sure.
For each of us individually.
Yep.
Yeah.
And the last thing is that there's only really been 20 or 30 cases of true aromatase deficiency or excess in men. And that's even on the National Institute of Health's website. If you go there and you look up aromatase deficiency, you're going to see that there's not been many documented cases in the literature. Mm-hmm. And so there's no reason for somebody to say they are, what's the term, a hyper-aromatizer.
Okay.
It's just a ridiculous term to have. You either are deficient in aromatase, you have true deficiency, or you have true excess. And there's only been roughly 30 to 40 cases ever reported. So you don't fall into that classification.
That'd be incredibly rare. Yeah, it's a shame because, you know, we were seeing all these clinics going up, and a lot of these people are being set up for problems in the future without really knowing it, and maybe not even getting the full benefits of the testosterone therapy as they should be when they're being optimized.
You know, a common thing that I experience when I have these consults with men, I have consults with men almost every day, and one of the there's two things that's really frequent when we get people that come from other places, other clinics, and things like that. Number one, they're put on an injectable form of testosterone right out of the gate. They're given an aromatase inhibitor, and they feel good initially for a couple of weeks, but then after they have taken the aromatase inhibitor, they start to lose their libido. They start to feel bad, and then the next thing that happens is about 6 weeks into it is their hematocrit starts to go up, and so it will be suggested that they give a pint of blood every so often. And what eventually happens in the latter part is they develop iron deficiency anemia, and they really get fatigued, and they don't know what's going on. And the clinicians that are doing this cannot interpret the blood work to see clearly it's iron deficiency anemia, stop doing the phlebotomy. But on the other end, with the aromatase inhibitors, it's sort of bizarre to me that, see, we don't have a protocol here. We just have a simple formula of what works most effectively. There is no set protocol. It is basically getting enough of the hormone and letting it do its job, letting it have enough time to do its job. Now, when an individual goes on an aromatase inhibitor right on testosterone therapy, and they have all these symptoms, they start to get it into their mind that they should start blocking estradiol because it's like a recurring cycle of symptoms. And so when they first go on testosterone, they feel good, but they're taking the aromatase inhibitor, they're still feeling good. But about the second or third week, they start to get the estrogen symptoms. And then they keep taking the aromatase inhibitor, but those are imaginary symptoms. They're brought about by the aromatase inhibitor, not by the aromatase estradiol. You won't even have the full aromatase estradiol until 6 to 8 weeks later when you've adjusted to the dose that you're on. Mm-hmm. So it's really problematic on many different levels for a cookie cutter approach like that to be applied to everyone, because number one, if someone stays on aromatase inhibitor for a decade, you can bet pretty much $1,000, $2,000 to anybody that their bone mineral density is going to be lower. Mm-hmm. Across the board. So it's one of the things where if something shouldn't be used, if there's no practical purpose for it, then why is it used? If you trace it back, the furthest I could trace it back was actually a suggestion by Dr. Neil Rouzier, and he talked about the Underground Steroid Handbook by Dan Duchesne, where he talked about obtaining aromatase inhibitors by complaining of symptoms of estrogen, like bloat, being emotional, things like that. That has really never, ever left. Ever since that era is permeated through, mm-hmm. even into testosterone replacement therapy. And any clinician that looks at that Pavlovich study, they should know that they can extrapolate out of a highly comorbid population to men on testosterone therapy that really don't have any problems except they're testosterone deficient.
Sure.
So.
Yeah. Well, that's really it's alarming that because it's in such common use, and that people don't really understand what they're doing with this, and that's the importance of finding a doctor that's really knowledgeable in this area when you're being treated for optimization.
Are you a man suffering with erectile dysfunction, or know of a man suffering with erectile dysfunction? Well, the answer that you are looking for is at myjunkdoesnotwork.com. You heard that right, myjunkdoesnotwork.com. What you'll find there are interviews on cutting-edge medical therapies to treat erectile dysfunction with experts in the field. That's right, experts. One of them is actually even a therapy that you can do in the privacy and comfort of your own home at a fraction of the cost of what it costs in a medical office. So what are you waiting for? You want to regain your confidence as a man? You want to regain your ability to pleasure your partner and yourself, both physically and emotionally? Don't wait, don't hesitate, don't procrastinate. Do it now. Go to myjunkdoesnotwork.com. You'll be glad you did.
You've alluded to this, but when you are starting testosterone therapy, how long do you figure before you're kind of in a groove, in a good groove of where you should be?
I think most people experience definite improvements around the 8-week mark on to the 12-week mark. Sometimes it takes 16 weeks. And there's a lot of things that I have to qualify that statement with. It's really hard because to really say when they're going to adjust, because there's a 40% variation in response from man to man in terms of how they respond to androgen therapy. And we have known this since 2006 when Nishlag released his study. And then there's also a high variation between different races as far as their sensitivity to their own androgens and therapy. But usually if patients will just be patient enough to get out of the moment by moment thinking and thinking longer term, if they can make it to the 8-week mark, on to the 12-week mark, they're good to go.
Yeah. Okay. Yeah, because a lot of people don't really know that really kind of takes. And it makes sense that it would take a while for your body to adjust and get up and going physiologically itself to accommodate increased levels of testosterone.
Well, if you think of like protein anabolism, retention of nitrogen, those effects take time to occur. So if you think of transcription and translation to make functional proteins and building tissue, lean tissue, that process is it's energetically expensive, and it takes time to do it. And so I think a lot of people think that testosterone therapy is a panacea, and it's not. And men that are truly deficient, they will respond across the board. When men are not truly deficient, for whatever reason, and they have bad lifestyle factors, they don't respond as good as these men that are truly deficient, because it's like a night and day difference.
Yeah. So that's just true. So Scott, let's talk about because you touched briefly on it. Because also I think there's a lot of misnomers about hematocrit and RBC levels when you're doing this. What can you tell us about this and the numbers and all that stuff?
Actually, this is something I've been working on for the past 2 years, and it's something that I intuitively thought that there was something wrong with what I was reading, and so now I do not consider androgen-related erythrocytosis to be pathologic, not when considering testosterone replacement therapy. I don't consider it to be that way now. And there's a lot of qualifiers for this. And one of the biggest is there's not a one-to-one correspondence between hematocrit increases from red cells and hypertension, or even hematocrit increases and thrombosis. So it has been assumed, because of observational studies and rheological studies, that an elevated hematocrit predisposes for cardiovascular events and also thrombotic events. But if you look at the experimental studies that have been conducted, there's actually a paradoxical response that occurs. And it occurs when there's just hematocrit increases solely due to red cell count increases. And this can be for any secondary cause. It could be for taking androgens. it could be hypoxia, it could be lung fibrosis, anything like that. So the response is paradoxical. It doesn't follow the normal rheology measures that are taken from static experiments. And what I mean by that is that when you measure viscosity on a plate viscometer or in a tube, a glass tube, it doesn't expand or contract. It doesn't mimic the internal physiology of the body that's dynamic. And so if you look at those measures that are taken on static experiments, any increase in hematocrit will increase viscosity exponentially.
Sure.
But experimentally, that doesn't occur. What happens is up to 33% above baseline, there's a paradoxical effect. The vasculature dilates more, the blood pressure goes down, the afterload on their heart goes down as well. But then there's an inflection point right after that where it will increase. And so if you consider starting at a hematocrit of, let's see, around 45, and you take 33% of that and add it to the top, you're never going to reach that level on testosterone therapy. Not 33% above baseline. It just doesn't. I've never seen it occur, even in athletes and bodybuilders.
Okay, all right. So that's also another number that needs to be looked at very carefully or discussed carefully with your physician, especially if they're reacting to it when you're on testosterone optimization therapy. So, well, Scott, I want to, if somebody wanted to work with you and Dr. Nichols and everyone there over there at Tier 1, why don't you tell us a little bit about Tier 1 and what you guys do over there and all that?
Sure, and thanks for asking. At Tier 1 Health and Wellness, we're a preventive medicine practice. We really love what we do with our patients because we establish relationships every day, and we're involved with really changing people's lives, really having just complete transformations in people. And so Dr. Nichols and Angie do all the hormone therapy here. I do the genetic consultations and nutrition, things like that. I'm also the director of clinical research at the Tier 1 Center for Research. Dr. Nichols and I are working on a couple books right now, and we're always working on papers to actually publish in the peer-reviewed literature. But our goal here across the board is to prevent chronic disease and extend a higher quality of life in doing so. And we've used hormones effectively to that end here. And so when I see people that are on 3 or 4 different hypertension medications, they're overweight, they're developing insulin resistance, and they just don't have the motivation. And then after a year passes, 18 months passes, and they clean up their lifestyle factors and they get their hormones in check, it's a night and day difference. It really is. A lot of people can come off medications that they don't need anymore. Some individuals obviously have to stay on medications for their whole life. But what we've seen as far as changes in the individuals here that we could help has been truly amazing. I enjoy working here. It's a pleasure to come in every day because I'm happy to come into work.
Well, good for you. Good for you. Well, I think you guys are doing incredible work over there. And I'm sure lots of your patients have benefited, and then others who aren't your patients just by hearing what you have to say can benefit. And so I would encourage you. And there are opportunities to work with you guys via telemedicine. Is that correct?
Sure. We're part of the compact, the telemedicine compact. So we're licensed in most states now. Some states we're not, but most people we can help out.
Let me guess, California is one of them.
Definitely. Yes, you got it.
That wasn't hard. And if I had to pick another one, it would be New York.
I'm pretty sure. Yeah. Yeah.
That you're not on. Yeah. So, so they can work with you via telemedicine and so there's opportunities so you don't have to go to Tennessee and visit you guys there.
Well, we always encourage patients before the COVID deal to come out and see us. because we want to meet our patients face to face so they can see who we are, talk to us. When that gets resolved, we want to start doing it again. But as far as telemedicine, yes, they can see us remotely, and we still can meet and talk. So
Sure.
It's all good.
All right. Well, I know you guys spend a lot of time on your initial appointments with people just to get an idea. It's not one of these things where you're on a clock because some private equity group owns your practice.
Sure.
Yeah. So all right.
They're full 1 hour consults.
Yeah. So you really get to know someone. So Scott, this was really very interesting. I've been wanting to get this out there because I know that there's a lot of people. I get asked about aromatase inhibitors all the time, and it's a thing that is out there. Unfortunately, it's more prevalent than it needs to be, and people are basically getting fucked up. To put it, is that a medical term? Fucked up?
Well, it can be now. Right?
Yeah, let's call it what it is, and so it's unfortunate. So Scott, until our next time, we can talk about some other stuff here sometime soon here. So
Sure.
So this is Oris, the old guy at oldguytalkstome.com. Remember, it's all about creating a kick-ass life for yourself and those that you love, and be sure to subscribe, share, and review, and all the information on Tier 1 will be in the program notes. Take care.
Now, I want to make sure that you do 3 things. 1, subscribe so you don't miss any of these episodes. 2, share it with your friends because they need to hear this information also to get this stuff so they can have a kick-ass life. And 3, review this podcast. And if you've got a bad review, that's fine too. Thanks for listening. And be sure to subscribe, share, and review. Until next time, remember, it's all about creating a kick-ass life for yourself and those that you love.